I'm making my comments quick. We are tight on time. I would want to quickly introduce Dr. Sherry Ling, the Deputy Chief Medical Officer at Centers for Medicare and Medicaid Services. And Dr. Ling has been a wonderful colleague with all of this work, and we're just really so pleased to have her with us today. She is short on time and will stay as long as she can. And I will introduce her and let her begin her presentation. Thank you so much for being here.
Thank you, Amy. Are you able to hear me? Can someone confirm?
Yes, we can hear you.
Okay, terrific. I was trying to share my video, but received a message, cannot start because the host has stopped it, but that's okay. I think you know what I look like. So thank you again for all of your work and for including us today as part of this esteemed gathering. And for those of you who are practitioners and providing care to our beneficiaries, a special thanks. I have to say, every Alliance meeting that I attend, I learn something new from both the people who are receiving care, our beneficiaries, who are sometimes called patients, and also from all of you who are incurers of service. So many, many thanks. If I could have my next slide, please. So this is just my federal disclaimer that I'm obliged to show. I have no financial conflicts to disclose. And what I will be speaking to is some of our policies, that all of which have been finalized, some emerging information, and also beyond that, really sharing my perspective as a geriatrician, rheumatologist, and internist. So thank you. Next slide, please. So just by way of reminder, the scope and reach of CMS by way of Medicare and Medicaid and marketplaces is that roughly we touch upon the lives of 1 in every 3 Americans. And next slide, please. And one of the challenges that we've been observing is that, our population is becoming increasingly complex. There are many moving pieces to the therapeutic landscape, new challenges every day, including a pandemic that had really challenged us, even as we had been rolling out our acupuncture national coverage determination. And as has been shared today, many new challenges that I think we have to seize the opportunity to learn from, so that we can build a better system together, a system that delivers to the services and care that the people who we serve really need and can benefit from. So this slide just depicts the 16 agency priorities that we are strategically focusing on to serve our beneficiaries. Now, at 3 o'clock is the tab that is about fighting the opioid epidemic. And if you were to go beyond that and actually Google search the CMS 2020 roadmap, fighting the opioid crisis, you would actually see that the 3 areas of focus are preventing OUD or opioid use disorder, better treating OUD, and also using data. And for that first pillar, pillar of focus, we have actually built in the following, that OUD prevention is accomplished when pain is better managed using safe and effective range of therapeutic options that rely less on prescription opioids. So I think building on what has been shared thus far today, it's a matter of, and I think Cindy, you said it so well earlier, which is about finding the right treatment for each and every patient or beneficiary, and to think about this in a more comprehensive way and better integrated way, although our coverage determinations are really addressing each and every treatment and service on an individual basis. But, you know, the patients who we serve really require a fulsome discussion of what the therapeutic options are with the goals of care that are clearly articulated, and that care can and should delineate what the risks and benefits and the trade-offs of any of the therapeutic options are, so that the patient, person, and clinician can together outline what the most appropriate treatment strategy for each of our patients. Next slide, please. So as I mentioned, the Medicare and Medicaid populations are becoming increasingly complex. Just to illustrate, this is a fee-for-service Medicare snapshot, cross-sectional data from 2017. With each year, it gets more and more purple. Purple depicts the beneficiaries in the Medicare population who have 5 or more conditions in addition to the initial target condition. And several of these can cause painful symptoms such as arthritis, osteoporosis, and so on and so forth. So as you can see, what is blue is that which is that single condition. So there's more purple here and more that is not blue. So it just illustrates that pain management has to consider the person with their goals in mind, also with mindful attention to all else that comes into the therapeutic picture when you think about the complexity, the comorbidities, the other chronic conditions that each and every person may have. Next slide, please. So when it comes to Medicare coverage, and forgive me for repeating this, but I think it is worth restating that by statute, Medicare must consider that which is reasonable and necessary, and in the diagnosis or treatment of an illness or injury, or to improve the functioning, and this is straight from the statute language, of a malformed body part or body member. So, you know, it really started with a very discrete focus on treating, fixing a specific impairment or condition. So that in many ways, along with the fact that Medicare is a defined benefit program and beneficiaries are defined by age, by disability status, by end-stage renal disease, with specificity on who is considered an official and Medicare provider, and also what settings are permissible to participate in Medicare. So these are kind of the statutory constraints, if you will, that help to frame the Medicare program and may provide you with some understanding of how and why our coverage determinations read the way they do. And, you know, as an example, I'll go into a little bit of detail about the acupuncture coverage determination as an example. Next slide, please. And this is the process. What is depicted here is the national Medicare coverage process. It is also laid out in statute. There is a request that can come in from any member of the public, from an industry partner. So what appears here is the statutory process for the national coverage determinations, and included in this, there is a time window from the time that a request comes in to the time that the final decision is. So suffice it to say that if you go to the next slide, this is the national coverage process. And note that there's a public comment period built into the coverage process. And there are also local national coverage determinations that the Medicare administrative contractors actually run by way of the authority that they have to cover and pay for specific treatments and services. I will also say that their process includes opportunity for feedback and public comment. So I know there were questions about how might we influence or feedback on whether it's acupuncture or any other future topics. So, you know, as we post and notify the public of these considerations, it will be specified on the timing and the window for public comment, and that is the best way to provide that type of feedback. Next slide, please. So a little bit about acupuncture for chronic low back pain. This is a national coverage determination that had specificity as to the condition, as well as the number of treatments and the conditions with which or under which the coverage would be permitted. To suffice it to say that this was based on the review of the available evidence as it applies to the Medicare beneficiary population. So as you think about additional therapeutics or treatments that are of interest to this community, keep in mind that often the studies that the trials, the clinical research studies, either don't often include Medicare beneficiaries by age, nor by disability status, but that presents a challenge when it comes to applying that evidence to Medicare policy, because the policy has to be about the treatment and services for our beneficiaries. So just to keep that in mind, many of you are involved in clinical trials, real world evidence gathering of information. So this is something that I think is well worth noting. Next slide, please. So we did receive a few questions about, who can provide the service. The coverage determination specifies that a physician may furnish acupuncture in accordance with the applicable state requirements, also specifies additional personnel who can furnish acupuncture if they meet the state requirements. The furnishing personnel must be under the appropriate level of supervision by a physician assistant, or nurse practitioner, or clinical nurse specialist, as required by the Medicare regulations. We did get a question about the specificity of the supervision, and I will just, if I may, just read that the supervision is direct supervision. That is, the supervising individual must be immediately available to furnish assistance and direction through the performance of the service. Now, that does not mean it needs to be the same physician or other practitioner who is really managing that patient's care more broadly, but this is that the physician or other professional has this supervisory role, and that, because that is the individual who will be billing Medicare. Now, Medicare Advantage has the ability and the flexibility to must cover at least what fee-for-service Medicare covers. So there's mirroring there, but has flexibility to go beyond the specificity of what is outlined for fee-for-service in the fee-for-service policies. Next slide, please. And this just gives you additional information about what some of the educational requirements are, the billing requirements, a response to if a chiropractor fulfills the requirements in the decision memo as auxiliary personnel. That would be a eligible professional who could provide acupuncture by way of incident to a physician service, and other further details. that cover what type of acupuncture. But all in all, this is about chronic back pain. We have received, suggestions about other conditions, and no doubt, when it comes to consideration for other conditions beyond chronic back pain, that we will require additional evidence with specificity that applies to the Medicare beneficiary population. So it is about the science and about the evidence. Next slide, please. So there are a few additional policies that are worth mentioning that I believe has at least theoretically been a additional assistance to our beneficiaries with chronic pain. That is the Chronic Care Management Service codes and the Behavioral Health Integration Service codes that are really available by way of the links provided here. I mentioned these because we understand that, especially throughout the public health emergency, it has been difficult for our beneficiaries to come in for in-person care, and in fact, elective services had been put on hold because of the need to address the surge in many locations. So these services were designed with non-face-to-face service delivery in mind. So this will not appear on the telehealth list, but that is because they're already providable and billable by way of for non-face-to-face encounters. The Medicare Wellness Visit and also the Welcome to Medicare visits also can and appropriately should address pain management, and if the pain is a condition that the beneficiary actually has as part of these services as well. It is a comprehensive look, and to come up with a personal care plan that I also alluded to earlier. Next slide, please. And I already mentioned the Medicare Advantage organizations that these benefits certainly could include medically approved non-opioid pain management and integrative services, complementary or comprehensive services such as those listed here. A massage must be ordered by a physician or the medical professional to be considered primarily health-related and not primarily just for relaxation or comfort. This is language from the manuals. But hopefully by seeing this, it provides you with some guidance of how to approach the request for said care and services. Next slide, please. Now, as far as how things are going with the acupuncture trial, as I mentioned, many aspects of care had been put on hold. We did see a decline in fee-for-service claims pretty much across the board in the public health emergency, on top of which we have a claims lag, and it takes a while for those claims to mature in our system. So we don't have direct information based on our own claims analyses yet on the extent to which the acupuncture services are being utilized, where they're being utilized, by whom, and any type of details. But we are really interested and looking forward to the time where we can do those and conduct those analyses. But many of you who are already engaged in survey work, if you are gathering that type of information, and if you're identifying potential barriers to promising care and services, we really are interested in receiving that information. And in fact, as stated here, one of the requirements for CMS to implement has been the Support Act, and under Section 6032, CMS had the obligation to really review and address payment and coverage for therapies and devices for the management of acute and chronic pain, including recommended demonstration models and consultation with the Pain Best Practices Task Force that was led by our Office of the Assistant Secretary for Health and Dr. Vinyala Singh, and as well hosted a public meeting, and thank you, Cindy, and others for being part of that meeting. All of that information is being compiled into a report and an action plan, all of which will be forthcoming and released to the public soon. Next slide, please.
1 minute.
Thank you. We also have the section 6086, which is the Todd Graham pain management study that we're working closely with our colleagues in the Agency for Healthcare Research, really to understand what the barriers and impediments are to evidence-supported care and services as it applies to the Medicare population, and hosted several listening sessions as well as a MLN specific listening session recently, as recent as yesterday, and are gaining some insights, and then we'll be putting forth a plan to address some of those information and evidence gaps. And what is an evidence gap is also a research opportunity. Next slide, please. So some of the stakeholder comments received really are those that have been echoed throughout today's conference, including access, cost, payment, need for non-opioid alternatives, and a better synthesized approach that certainly could be the topic of study. Next slide, please. And the two final slides, I just wanted to mention, because we have an open response for comment, that is section 2003, which is about electronic prescribing of controlled substances, the e-prescribing requirements. And an RFI, request for information, remains open until October 5th for comment, and we hope that you will respond to this. It will be exceedingly helpful for us. Next slide, please. As will be the proposed rule under Section 2002 of the Support Act, which requires the Welcome to Medicare and annual wellness visits to include new screening for potential substance abuse disorders, risk factors, opioid prescribing, and the like. So please do, you can download the proposed rule through the site provided here, and really do look forward to hearing more from you. So with that, I will end my remarks. And again, Amy, thank you for all that you do, and to all of you for attending.